Hey everyone, my name is Dr. Galatia Strong. I'm a physical therapist who got a 100% on my NPTE, and this led me to co-found SPT with me, which is an NPTE prep platform. If you enjoy what you see and you're studying for the NPTE, check out our courses at sptwithme.com. Now, for what you're actually here for, let's talk about the visual pathway and defects. My goal for this lecture is to have every single thing about the visual pathway and defects to be crystal clear so that you never have to visit another video. So I want to start off talking about the left side of this image that you see. This is a top-down view of the visual pathway. It's a cross-section. It shows our eyeballs. You're going to follow that tract, follow the red and blue lines. And you're going to see that it turns into the optic nerve. This information is going to be sent to the LGN, the lateral geniculate nucleus. It's in the thalamus. Then after that, we have optic radiations, and information is sent to the primary visual cortex, which is where all information from the visual field is going to be processed. This is purely an afferent pathway, so nothing motor is happening at all. What I want you to notice is that each eyeball has two tracks. If we're looking at the left eyeball, there's a blue line and a red line. If you're looking at the right eyeball, there is a blue line and a red line. You're going to see that for both eyeballs, the blue line is on the left side, while the red line is on the right side. So within each respective eyeball. Now when we look at the left side of each eyeball, so the blue side of each eyeball, the blue tract, look where it is that the visual information is given from. It's the contralateral side. So both the left and the right eyeball, on the left side of each respective eyeball, we get visual representation of the right field of view. Same thing, but of course opposite happens with the right side of each eyeball. The right side of each eyeball looks at the contralateral visual field, which is then the left visual field. So we are already starting off with a crossing over in a sense. Now, let's follow these blue and red lines, and we're going to see that it eventually reaches a junction, and this junction is called the optic chiasma. Now, what I think is tricky is that sometimes when we learn about the optic chiasma, you almost feel that everything crosses over. But if you look at the colors, you can actually see that is not the case. So for example, I want you to follow the two blue lines coming from each respective eye. You're going to see that these two blue lines, even though they were on different eyes, they both end up going to the left side of the brain. While the two red lines, once again, even though they're on different eyes, they end up going to the right side of the brain. So we're no longer blue, red, blue, red. When we enter the brain, it's blue, blue on the left, red, red on the right. Now, when we're talking with respect to sides, of course, it's not blue and red. It's left versus right. Now, looking a little bit more into depth, so if we follow the two left sides of the eye, so the two blue lines, you're going to follow them both to the optic chiasma, and you're going to notice that the left side of the left eyeball stays on this left side, while the left side of the right eyeball, this is the one that actually crosses over within that optic chiasma to come over to the left side. Same idea on the right side. Let's take a look at that. The right side of the right eyeball is going to stay on that right side, communicate information to the brain on that right side, while the right side of the left eyeball crosses at the optic chiasma to then provide information to that same side, to the right side. Now after the optic chiasma, again, we end up giving information to the LGN, the lateral geniculate nucleus. We are at the thalamus. Then after this, we send information to the primary visual cortex via the optic radiation. Now, this image does not do a great job in showing the true structure of how the optic radiations look like. So here's a better picture. This is obviously a lateral view of the brain, and here you can see the optic radiations through its depiction as an array of lines. You can see that there is one section that kind of curves upward. This is a set of the optic radiation known as the superior optic radiation. Then there's one that curves downwards, and this one is known as its own set of optic radiations known as the inferior optic radiation. And it has another name, the Meyer's loop. Now the reason this is important to know is that the superior and inferior radiations, they have different jobs. The superior optic radiation, its job is to provide information about the inferior portion of our visual field. So far, if you think about what we talked about in the last slide, we've only talked about the left and the right visual field. But this area, the optic radiation, is where we can integrate an even more complex component of our visual field by adding a superior and inferior visual field. So we talked about the superior. Now the inferior optic radiation's job, aka the Myers loop, its job is to provide information of the superior visual field. So kind of just like we saw in the previous image, there's a lot of contralateral and things that are opposite to what you would expect. It makes it a little complicated, unfortunately. Now, the inferior radiation gives information about the superior visual fields, while the superior optic radiation gives information about the inferior visual fields. So just keep that in mind as we continue. All right, so we're going to go into how each potential lesion could present. Now, before we even get into this, there are two ways that I want you to think about how to apply this information. So let's say, for example, your patient has an MRI, and this MRI shows a lesion at any of these places. As a result, you know where the damage is, so then you can rationalize how the visual field is for your patient. You can rationalize where your patient can see and where they cannot see. So the opposite is true as well. Let's say you don't have an MRI and your patient is just coming to see you. You're the first person that this patient is seeing following all their symptoms. So as a result, you're going to do your visual field test, you're going to do your cranial nerve 2 test, you're assessing all the quadrants, visual field locations, and let's say you can tell there's an impairment in one of the quadrants or one of the sides. Well, as we go through this lecture, as we go through these examples, you should be able to deduce where exactly a lesion may be or where it might not be. So if you have an image, it's going to tell you a lot. But if you don't have an image, it can still tell you a lot as well. You just have to understand the tracks and how they present if there's a lesion along any part of it. So just some food for thought. Now, something else I want to mention is, if you take a look at this image, it's clearly a different image compared to the one that I used previously. However, I'm just using this one for the purpose of explaining, and because I like how this image in particular shows some depth. And what I mean is it shows the superior versus inferior optic radiation. So in this image, as you can see, the lesion A is going to correspond with how the visual field defects look under letter A. Same thing with B, and the list continues. So consider the left side of the image with that cross section of the brain. It corresponds with the right side of the image of all those circles, which represents the visual field of each eye. This is a zoomed in image of the same exact one from the previous slide. This just makes it a little bit easier to explain. You don't have to think about so many things. But in this example, we're going to look at A, B, and C, then we'll do the rest on the next slide. What I want you to note is that in the visual field part of this image, so look at all the circles on the right side representing the eyes. Just note that what is in pink is what you cannot see. In the white areas is what's considered normal. You can't see through it. So let's go through each example. Let's look at letter A first. It is suggested that there is a lesion on the retina, and in this case, it's the right side of the right eye. Now, what you can see is there's nothing going on with the left eye because there's nothing there. But on the right side, you're going to see a little smidge on the left side. This should make sense because with respect to the visual field, when you're talking about the right side of the right eye, it looks at the left visual field, which is why you see it on the left. Now, the reason why it's a little smidge is because you're just having a small lesion in a small place of that retina. For example, if you saw a tiny, tiny lesion a little higher, the visual field is going to reflect that. If it's a little bit lower, it's going to reflect that as well. Now, let's talk about B. This is a lesion at the optic nerve. So, on the right eye specifically, the left side of the right eye and the right side of the right eye are affected. Nothing is happening on this left eye at all. So the left eye should be fine, which it's suggested that it is. But on the right side, absolutely no information from either of the tracks on the right eye are being sent to the brain. And because of this, that's why we see a completely pink circle. No information, no visual field is sent from the right eye. And that's why we get what's called monocular visual loss. Then lastly, let's talk about C on this image. C suggests that there is a lesion of the optic chiasm. Now really pay attention to which specific tracts are affected. You can see that C goes straight up and down. There are only 2 out of 4 tracts that actually cross. So as you can see, the ones that actually cross over are the right side of the left eye and the left side of the right eye. Take a moment to really reflect and consider what we've already talked about. The left side of the right eye sees contralateral information. So it's going to get information from the right side, while the right side of the left eye also gets contralateral information. It's going to get information from the left side. It's the 2 that are in the middle. So think about if we separate our eyes into 4 areas, right? We have right side of the right eye, left side of the right eye, right side of the left eye, left side of the left eye. The 2 that are in the middle are the ones that actually cross over. Now, it seems a little confusing, but really just follow the tracks and you're going to see that the information on the outer side, the visual information, those are the ones that are affected. This is called temporal hemianopia. So your patient is only going to be able to see in the medial visual field, and they unfortunately cannot see anything on the lateral peripheral field of each eye. As you can see, we are using the same image and we're just zooming back out. If I were to just show you the bottom half of this image, you wouldn't be able to see where the tracks actually begin from. So let's move on to D. This is suggesting that the optic tract is being affected, specifically on the right side. The optic tract is not the optic nerve. The optic tract occurs after the optic chiasm. So even though it shows that there's a lesion on the right side, it doesn't mean that only the information from the right eye is affected. This is occurring after the optic chiasm. Remember, things have crossed over. Like I mentioned before, everything on the right side from both eyes ends up converging to the right side of the brain. So in this case, the right side of each eye is now affected. Well, what does the right side of each eye tell us? It gives us information on the contralateral visual field. So in this case, it's the left field of vision, and that's exactly what we see that is impaired. Contralateral homonymous hemianopia. Now let's talk about letter G and H. Remember how we discussed that there is a superior and inferior optic radiation. Superior radiation affects the visual field of the inferior visual field, while the inferior optic radiation is affecting our ability to see the superior visual field. Now, when both of them are severed, which is what letter G is suggesting, wouldn't both the inferior and superior visual field be affected? Furthermore, it's the same information that's being sent of the red lines. And this is exactly why you see the same exact visual field defect as letter D. It's the same information because both the superior and inferior optic radiations are affected. If it's only one, say just the superior or just the inferior, that is going to give a different impairment. And we're going to see that in the upcoming examples. But in this case, because both are affected, top and bottom, that's why it looks exactly the same as letter D. Next up, we have letter E. Once again, the tracts that are affected are the ones on the right side of each eye, which gives us information of the left visual field of both eyes, which is why we see that the left side is the one that's affected. Now, how come it's only 1/4 of our entire field? Another way to think about it is, why is it only half of that left field? Why is it only affected in that particular region? Well, in this diagram, E is directly placing a lesion on the inferior optic radiation. The inferior optic radiation gives you information about the superior field of view. This is why we see an upper left quadrant visual field deficit in this case. You look at the letter J, you're going to see that it's kind of in a weird place in this diagram, but the idea is that you are still on the optic radiation, just at the very end of it. What this is trying to suggest is that it does not matter whether you have a lesion at the beginning, the middle, or the end of the optic radiation. If there is a lesion anywhere along the optic radiation, it's going to result in the same manner because it eventually goes to the primary visual cortex. Lastly, let's talk about F. F is a lesion on the superior optic radiation. The information is still being sent from the right side of both eyes, which is why we have information from the left visual field as a defect. However, only the left inferior visual field is affected. And that's because the visual field deficit is from a lesion of the superior optic radiation. This gives us information about the inferior field. So this is why we only see a fourth of our visual field affected with this lesion. Lastly, letter I, same situation. Same situation as letter J. It is just trying to show you that regardless of location along that optic radiation, a lesion anywhere along that tract is going to result in this type of defect. Now, with respect to how to study this information, of course, when you're first learning it, it's very confusing. There's a lot of crossing over. There's superior, inferior, lateral, side to side. I get it. Now, first thing that comes to mind is obviously drawing it. If you are someone who really benefits from drawing and you enjoy drawing, then draw it. It's a great way to learn. Now, the reason I put a ... question mark is because I'm not a huge fan of taking the time to draw because I get really frustrated because I'm really bad at drawing. So I'm going to explain another way to study this information if you're anything like me. So I will say it's a little bit like drawing, but instead of seeing your horrible work on a piece of paper, you're just kind of tracing the pathway in the air. So you think about using your middle and index finger and use these as your pathways, right? I mean, you can look at an image either on your screen or if you're looking at it on a piece of paper that you've printed out or maybe you have drawn, just consider the pathway. Like I've talked about, only the middle two tracks are the ones that cross the optic chiasm. So consider which ones go to the right side, which ones go to the left side. Then after that, it's a matter of, okay, well, all this information from the right side of each eye is on the right side. Then you get to the optic radiation where now there's information going to the superior versus the inferior one. So it's just a matter of repetition. Try to draw it with your fingers and really just think about it. Even though this information is kind of confusing and there's a lot going on, what's nice about this subject is that it's not an it depends situation. It is a straight memorize how it's all laid out and just testing yourself to see what visual field defects may occur with different lesions. Good luck. If you enjoy learning information this way, check out our courses at sptwithme.com when you're studying for the NPTE. Check out these references if you need more information.